Good morning again. Let's start the keynote lecture. Today we have very special speaker for our society's 30 years anniversary keynote lecture, who is Dr. Yulun Wang. Actually, you know that during my residency period, Professor Chi, he first used the ESOP in our hospital. So it was a kind of shock for us, because that the Professor Chi was not talking to the resident. He was talking to the machine that move in, move out, that kind of things. So who developed that system? Who is Dr. Yulun Wang? Actually, he's quite well-known innovator and entrepreneur. And he is currently executive chairman and co-founder of Sovato Health, which is working to enable broad-based telesurgery. And he's co-founder of World Telehealth Initiative, a nonprofit that uses volunteer clinicians and the telemedicine to deliver sustained healthcare expertise to impoverished areas of the world. You know that first robot, the JUICE system, was the one that was used for the transatlantic, the Lindbergh operation. And it's been, so we invited the right person to commemorate our 30 years anniversary, because Dr. Yulun Wang developed JUICE system, and although now is a kind of, the mother of the Da Vinci surgery. Okay, let's welcome Professor Yulun Wang, and he will give us a talk regarding legacy and vision, 30 years of robotic surgery and the road ahead.
So it's, again, a real privilege and honor to be speaking before this esteemed group today. And I'd like to, again, thank Professor Wang and Professor Kim for the opportunity to deliver this, this talk. And you can see by my title, it's 30 years of robotic surgery in the road ahead. And obviously the 30 years is aligned with the 30-year anniversary of KSERS. And so what I'm going to do is I'm going to go back in time, and I'm going to talk a little bit about the history from my perspective, and so I apologize for not being comprehensive. And then I'm going to talk about specifically the evolution towards some of the new technology and capabilities that I'm working on, which is around remote surgery and AI, because I think both of those advancements are going to play a significant role in the future of surgery. So I'm trying to advance. And, is it this guy? Oh, got it. Okay, quick user error there. But so I'm an engineer by training. I wasn't skilled enough to become a surgeon, and so I started working. I just fortuitously ended up in medicine. I did train in robotics, and so I became familiar with what was happening in medicine right around 1990. And if you look at this graph, that's meant to say 86, 87, 88, 89, 90, 91, 92, 93, 94, et cetera. And it's talking about the conversion of cholecystectomy from open to laparoscopic. And you can see it happens right around the 91, 92 period, which is soon after that when the KSERS organization was founded. And this created a tremendous opening for putting new technology for advancing the field into surgeons' hands. And as Professor Wang just mentioned, where I got involved was I built a robot called ESOP. And ESOP, the idea of ESOP wasn't what the robotic systems are today. It was a subset. It was basically just the camera arm. And the problem statement that was said to me was that surgeons, as they converted from open to laparoscopic, lost control of their eyes. It's like you and I in a dark room, you have the flashlight, I want to look where I want to look, and I have to tell you where to point that flashlight, and there's constant correction. And so the first idea of ESOP was to make a 3-arm surgeon. And this actually is interesting because, as you know, most robotic systems now are 3 and 4 arms, and it enables more control under the direct control of the surgeon. And you can see here in the picture on the right, since we got some funding from NASA, they actually put us on the cover of their magazine. And that was the first robot to be cleared by the FDA. And that was around 1993. And then what happened was, okay, laparoscopy had really taken off. And it's basically what to do next. And so we had actually roboticized the holding of the camera or the visual field. So the next domain was obviously to roboticize the instrument. I think you all recognize what's drawn here is a laparoscopic instrument, and it's cut in half, and a computer is put between the two halves. And this is effectively what a robotic system is. It takes the laparoscopic instrument and it computerizes it. And so I think it was Professor Chi up in the speaking in the beginning of today, being a pioneer here in Korea in bringing robotics into the field of surgery. And I think that what I've always believed why it was inevitable, because it was difficult in the beginning, and I appreciate Professor Chi's words in terms of, fighting perhaps an uphill battle to begin with, but you just cannot deny the computerization of things being the continued advancement. And so when you have a computer here between the handle and tip, you can do all kinds of things. First, and it's not drawn here, you can put a wrist on the end, and you can make that, and then you can make that wrist in the motions of those tip map however you want to the handle. You can eliminate tremor, you can scale motion, you can make the motions much more intuitive in terms of the orientation of the visual field to the instrument tips. And that's effectively what the robotic system we're doing. And so they turned into different types of formats. This is the one that I worked on, which was called Zeus, and as I'll get back to in a moment, how that's moved into telesurgery. But you can see now the surgeon is separated from the patient through electronic communications, and obviously the one which has become the dominant player in the marketplace is the Da Vinci system. And so this area, and I'd say KSERS is one of the innovative organizations and societies pushing this. The adoption of robotic procedures is continuing to increase. And I only have a subset of it here, but you can see some of the procedures have definitely become the standard of care, and others, to be frank, are on the way towards that. So the adoption of robotics is, I would say, very healthy, and it's going to continue evolving in that direction. Now let me kind of move a little bit in a different direction and talk about another huge capability that robotic surgery enables. Because the capability I've talked about so far is really improving precision and dexterity, okay? Now, problem statement is that, 2/3 of the world's population don't have access to high quality care. That's 5 billion people. That's not a small number. A lot of those people can even pay for it. Many of them can't. But the issue is to be able to bring high quality care around the world is something that we can technologically do now that historically we have not been able to do. In this slide, it shows about 150 million people per year actually don't get surgery who actually have the ability to pay. There are areas of the world, obviously, where other things are going to have to do to help them. So if we go back to this slide and we talk about the computerization of the surgical instrument, As I already mentioned, because of the computer algorithm here, you can map the handle to the tip however you want, but also you can separate the two. Because of this structure, the handle can be 3,000 kilometers away from the tip. So this is a whole nother capability which is now enabled because of a convergence of events which are taking place today. Let me go back in history a little, and I apologize for being US-centric, but the concept of telesurgery is not new. It was in the 80s, 1980s, when DARPA, which is a major US funding agency, funded SRI, Stanford Research Institute, to work on battlefield telesurgery. Many of you may know the name Dr. Rick Satava, who's been a pioneer in this area. Dr. Phil Green was the lead engineer on this, and they worked on telesurgery. Now, it was early, and to be frank, they made some early prototype-ish things, but it was too early to really do it with any type of anything other than a well-controlled demo. I was involved with Computer Motion to do some actual clinical cases. This was done by Professor Lou Cavusi at Johns Hopkins, and he actually controlled an ESOP arm in Italy from Baltimore in order to do some biopsy work from Baltimore to Italy. And then the one which receives quite a bit of attention is this one where Professor Jacques Moresco, who sat in New York City, and he took out the gallbladder of a woman in Strasbourg, France. And this was done on September 7th, 2001, so actually 25 years ago. And so I'm going to show you a quick little video on that. It's a 25-year-old video.
Camera right, please. Right, camera right. Move in, stop. Okay, it's perfect.
Modern medicine just took a giant step forward in making everyday surgery accessible to patients.
I think we're missing the other audio channel. So I'll just go ahead and fill it in verbally. So that's happening in Strasbourg, France. And then he's not in a hospital, he's in a telecommunications center in Manhattan. And we had a fiber optic line, which was dedicated by France Telecom. This was probably the most expensive surgery that's ever taken place in the world.
It was impossible to imagine 10 years ago, or perhaps, yes, a little less, that this kind of operation from New York to Strasbourg will be possible. That's the reason why the name is Lindbergh operation, because I think it's going to be for surgery a very, very big symbol.
We are doing it at a distance. This patient is cured, and yet is several thousand miles away. It's fantastic.
Okay.
So what it's talking about is the fact that actually the president of France got the CEO of France Telecom to provide the fiber optic
Robots
line.
combined with telecommunications can allow
That's me
a
25
remote
years ago.
surgeon to interact collaboratively
I haven't aged a day.
on a patient where that surgeon doesn't even exist. It can be thousands of miles away, as shown here.
Tu n'appuies pas sur le truc ou quoi?
So it was a gallbladder cholecystectomy. It took about 55 minutes. It was actually done very successfully, very much like a normal surgery. It was 150 millisecond
The
round
quality
trip
of the
latency.
picture is better than the majority of the picture of surgeons in general in the world.
And so you can actually see, like, the monitors are still big, thick monitors at that point in time. And they're the robotic arms, which are actually, in this case, mounted to the table in order to move. So that was the Lindbergh operation done on September 7, 2001. And then Professor Meron Envari out of Canada took it to the next step, and he did a sequence of 20 procedures. I think colon resections as well as hernia repairs, and he did a series, and it's well published, about a 400 kilometer distance. He started to get in the process. How do you actually really do remote surgery at scale? So then what happened is that whole kind of effort died. It stopped. And so people say, why? Well, what happened was you had the introduction. I kind of showed you the thought process in the 80s to the 2000s. I showed you how it culminated in the Lindbergh operation and Professor Envari's series. And then actually what happened was the companies, the focus was really on just enabling robotic surgery, not remote. And so the companies kind of pulled back in that area, I think appropriately so, because the economics involved. So now if we advance to 2020, what's clearly happened by now is the concept of robotic surgery is now mainstream. And I think it's clear that robotic surgery is going to continue to proliferate in both types of systems, in terms of types of procedures, et cetera. And so, again, kind of basically a lot driven by industry at the request of people like yourselves, as well as hospital administration. The concept of remote surgery has resurfaced. And it's really going, at least from my lens, it's going very actively right now. Here's just a list of publications of the different press releases which have happened around the world. It's very global what's happening today. You actually have Vip Patel, who actually did some cases between Florida and Africa. You have XCath, which is an interventional cardiology or neurology type of device, and they actually reported on doing a mechanical thrombectomy remotely. You see many different things here, and you see in the center here, LivsMed, which is a Korean company, which is doing, we did a bunch of wet labs in order connecting from Santa Barbara to Chicago to show that was possible. Another Korean company in town called Rowan Surgical is actually doing remote procedures as well from endoscopy perspective, being able to go into the kidney and do stone retrieval. But the concept is that all of these robotic systems are applicable remotely as well as in person. So what's happened is there's been a convergence of two lines, which has been the enabler to start bringing remote surgery forward from a clinical and industrial perspective. If you go along the left line, robotic surgery came into play by improving precision and dexterity. The prostate procedure was very difficult to do laparoscopically, but you could do it if you had the improved precision. Then over, say, the last 15 years ago or so, what's happened is there's been more and more capabilities incorporated into these robotic systems. There's new imaging techniques. There's even some AI algorithms now being incorporated to enable the surgeon to even do better surgery than he or she could do otherwise. Simultaneously, on the right side, the concept of virtual care and telemedicine has been taking hold. And that's actually where I was the last 20 years. And things like telestroke, tele-ICU, neonatal care, et cetera, started being adopted because you had the shortage of a type of clinician and you needed to get that expertise to patients wherever they are. And that's what drove this right line. And in many areas of the world, including the US, there's tremendous activity happen on the right line. And then you put the two together and you have remote surgery. Now, what's important to know is that all of these advances along these different dimensions are not mutually exclusive. So if you take a robot where the precision, the dexterity, the added imaging technology, or what have you, all of those benefits also apply to remote surgery. So in other words, you can stack these benefits so that you can have super capabilities wherever those patients might exist. The convergence of these different capabilities have made it now possible, I believe, to have commercial remote surgery. One is that telecommunication infrastructure. As I mentioned during the Lindbergh operation 25 years ago, that line cost many hundreds of thousands of dollars to put in place for 1.5 hour procedure. Today, it's many, many orders of magnitude less expensive. The robotic surgical systems. I have a slide later. It shows about 250 different systems being built. Not all, they're all for all different types of procedures. The classical surgery that we're familiar with, single port endoluminal, endovascular, diagnostic, et cetera. What's really happening is the computerization of all these previously purely mechanical tools. When you computerize it, it turns robotic. When it turns robotic, it enables remote capability as well. The virtual care, COVID obviously had a huge impact on this, where people are now no longer afraid of getting their care remotely. And the last but not least, at least in the US, the regulatory and policy environment is now very supportive of this. So this is what virtual procedures looks like. If I play a little video.
This whole idea of doing telesurgery is real, and we are taking steps to prove it, and so it's been a very exciting day.
Hi, Dimitri, I can hear you. Can you hear me?
I can. This is going to be very exciting.
If you think about what remote surgery can bring to the world, obviously robotic surgery is perfect for it because the patient's already partly disconnected from the surgeon. Now we actually can say, can we actually have a surgeon sitting in one location, helping patients in many locations, or in many different operating rooms around the city, around the state, around the country. There are shortage of surgeons, shortage of expertise, and now we're going to democratize surgery by allowing the surgeon to operate in many places in the same week, in the same day.
So I see that you can actually move the tools from California to Chicago.
There's no delay. It looks great.
Imagine the patient not having to fly thousands of miles for expertise. Imagine the patient if they were suddenly in trouble because they were in an accident, coming into an emergency room with no expertise and having the best of surgeons take care of them.
We can congratulate Dr. Zerhouni that she completed the first 2,000-mile wet lab.
Congrats.
You guys are excellent assistants.
These are things that telesurgery and telerobotic surgery promises, and I hope we will all help as a group to deliver on this.
So hopefully you'll notice there were several different robotic platforms being shown in that video. There's the Intuitive, the Medtronic, Virtual Incision, and the LivsMed platforms, all kind of working remotely. So I think what's going to happen moving forward is this type of evolution. So I do believe that there's tremendous benefit for remote surgery, and so that's going to continue to move forward. And then which I think there's many sessions at this conference about it, is the inclusion of AI into the robotic system. And I think that's going to happen in a stepwise manner, and there's going to be augmentation capabilities to the surgeons along the way. And so that structure fits very well with the concept of remote surgery, because when you have remote surgery, you have this link where all of the data of the robotic system is traversing across, and you can now capture that data and you can apply it, you can analyze it and apply it back into the robotic system or wherever in order to improve the capabilities. As I mentioned, this area is growing by leaps and bounds. This is the 250 companies around the world which are building a robotic tool of some type, not just surgery, but also interventional, endoluminal, diagnostic, etc. And some of the categories, which I don't even have completely covered here, are all of these different types of systems, whether it's the soft tissue robot, orthopedics, neuro, diagnostic, et cetera, et cetera. And so it is, in my opinion, it's the process we're going through is the computerization of all tools for procedures. Today, there's about 5 million procedures done a year robotically. The opportunity is maybe 360 million or larger. So even though there's quite a bit of excitement and there's been huge progress in this area, there's tremendous more to go. And that's going to be very, very exciting to not only hopefully yourselves, the surgeons, because it enables you to do better surgery across larger distances to your patients. I think the companies will have more capability to deliver their systems for more uses. And then ultimately, I think the patient is going to be the beneficiary of this kind of capability. One thing which might not be obvious out of the gate is when you introduce, say, remote surgery, as an example, the types of things you as a surgeon might be able to do is be able to do more procedures. This is an example of an operating room. This was by the head of perioperative care for New York Presbyterian Hospital in New York City. The green bars are when they're sitting in front of the console operating. All the other time is wheeling in the patient, put them under anesthesia, taking them off anesthesia, cleaning the room, et cetera. What if you could actually enable yourselves to operate somewhere else while you're waiting between procedures? You could actually really up the productivity. Probably many of you have asked your administrator to give you 2 operating rooms. Now, the administrator doesn't want to do that, okay? It's beneficial for you as a surgeon, but it's not actually from the administrative standpoint. So this actually solves that problem. The pathway towards this remote, a future of remote procedures, we need to take carefully. We need to do it with caution, with careful considerations, with processes put in place. And this is something which I think, I think KSERS is an opportune place to take a leadership position in how to do this safely and effectively. And when you're doing it, to do these remote procedures, it isn't just that one block. A patient comes in to some remote facility and they start with a patient consult. And they might see a primary care doc. Then they might see a specialist. They might have some labs done. They might have to get some imaging done. All of this before the actual procedure takes place. The remote surgeon should probably have a consult with that patient ahead of time. The procedure takes place, and then there's follow-up activities which have to happen as well. All of these things will have to be taken into account. But ultimately, I think this is where geographic boundaries break down, where that we can collaborate across not only the country but around the world with patients scattered around the world as well. So with that as an end, I love this quote. I know that KSERS for the last 30 years has embraced this quote, and I hope that KSERS for the next 30 years embraces it as well. Thank you very much.
Thank you, Dr. Wang. It's a great talk and quite informative, and everybody must be quite interested, and they can see what will happen in the future. Okay, is there any questions or comments on one or two? So yeah, let me ask you. Yeah, Professor Kim. So while he's preparing, I just want to ask you to do a favor first, to give some remarks to the young surgeons to prepare the futures.
So I probably, the biggest thing on people's minds is AI and the influence, especially for the younger surgeons. And my own 2 cents is that I don't think we're getting to automated surgery, fully automated surgery anytime soon. I'm speaking from a technologist standpoint. I think, though, there will be continued improvements and the ways to augment your capabilities. And so I think that I would suggest, as a younger surgeon who has many decades in their career, I would embrace these technologies and use them to your benefit. Because what's often said is the person who, people aren't automated out of a job, it's the people who embrace the technology who put the people who don't out of a job. So that's my 2 cents.
Okay, thank you. So you don't need to worry about losing your job in the future.
Okay, thank you. Thank you so much. My name is Young Kim from a National Cancer Center, working for a National Cancer Center. And then it's a really great pleasure to meet you.
Thank you.
And then here, listen to your great visionary lecture today. And but I have one actual question and one comment, actually. But one question is about the major kind of limitation or kind of barriers for your vision as of for the remote surgery, telex surgery, because there are a lot of kind of technological or kind of legal or social kind of those acceptance. There must be a lot of limitations. So what do you think is the most important barrier for your vision? And the one comment is about the kind of value of the treatment. You know, in these days, because of the limitation of those kind of money, and all of the government all over the world are worrying about increase of those medical costs. So we are very much interested in, I think we should, the surgeons and doctors should have some kind of a value-based kind of a care, although there are a lot of opportunity for get those very fantastic new treatment. There must be kind of validation of those kind of value of those treatments. So I mean that in most of robotic surgery performed in all of the world in these days, I think the low value treatment. It means that there is no background of the evidence for those not showing any benefit of the robotic surgery. So surgeons, if we want to promote this kind of visionary surgeries, remote surgery to make a benefit for the patient, I think we need to focus on the practice to the high value treatment for those very expensive, although it's very valuable. So what do you think about that kind of aspect?
Well, thank you for your comments and your question. So if I start on the barrier one, there's a lot of barriers, and it's not going to be easy. The technology is very doable, but I think that it's non-trivial. Then there's the regulatory barriers. Those are non-trivial as well. Then there's reimbursement barriers, which are problematic. Now, so then why do all of this? Because in my opinion, the value is tremendous. The value, and this is a little bit to your comments of the second part, the value, robotic surgery, and there's still challenges about the benefit of it. But what is not challenged is the value of getting the right surgeon to the patient effectively. And that's what remote surgery does. It's not giving you this tool versus that tool, and then the comparison is perhaps close or something, and some people believe it's better, some people it's not. This is about getting your expertise 1,000 miles away. So one might think, well, the patient should just drive to me, which is what's done today, okay? But if the patient was able to get their procedure by the top surgeon where they are, it's just better all the way around. It's better for the patient, it's better for the family. And I could talk for a long time on this point, but I won't. I'll make it short. Is that usually the specialists are concentrated in the dense areas of the city. people are all over the place. If you can actually broaden that expertise all over the place, it actually brings tremendous value and it should lower cost. Because if you look at the diagram I showed of about like staggering procedures, Professor Yulun Wang, who was on the video I showed, he believes he's the chair of surgery for City of Hope. He believes he can up his surgical capacity 2 to 3 times. It's not proven yet, but those are the types of things which actually can greatly improve the cost structure aspect, as opposed to thinking about it just buying another piece of, call it expensive equipment.
Okay. Okay. Thank you very much.
Thank
Dr.
you.
Yulun.